Welcome, everyone, for our last session of today. I'm extremely pleased that we have three absolutely fabulous speakers here today. One from New York, Holly Crelly here. We also have Dmitry Nipogodiev from the University of Birmingham. And on the corner we have Ruth Cousins from this institute and now Discovery. I think what I'd like to do is jump right into it, but not before mentioning two very important things. One is some evaluations that you see scattered throughout the tables. Please do make use of them. And the second bit is you see a Slido link. Slido is a website. If you have a mobile device with you, you can go to the website, slido.com or .co.uk. I think Google can tell us. And then you can fill in this number. And that number we can use to provide questions. The questions will come up later on the screen, and some of the most popular ones will integrate into the panel discussion that we'd like to have after the short presentations. Each of the speakers today will speak for about 10 minutes, and beforehand we said, let's just provide some bit of an introduction to the three differing but overlapping topics around the topic of fresh approaches to ideas for rapid evaluation. And then have plenty of enough time to keep some discussion going, think about cross-cutting themes, and use both Slido, and of course we can always supplement it with the more traditional ways of asking questions. So please do use the Slido if you feel you like to put in some questions, and you can also use the voting button for Slido to say, oh, that's a question I also find really interesting, and I'd love to see that being integrated in the discussion. So without further ado, I'll give the floor to Holly.
So, hello everyone. So, hi everyone. My name's Holly, and I run something called the Rapid RCT team, which is a team that's based jointly at NYU School of Medicine and in the big hospital that they run in New York. And I'm going to talk, just as Jan says, for about 10 minutes on A/B testing and rapid RCTs, and kind of give a bit of an introduction to them and some ideas about whether or not they're a useful thing for us to kind of use in healthcare and how we might use them. Oh, God. So the first thing to say about A/B testing is, which I'm sure most of you realise, it's everywhere and all around us and being constantly done on us all the time. So one example that I like to give to start off when I talk about my team is the New York Times. So as you may or may not know, pretty much every morning they rapid test all of their headlines. So they're showing you a random option and seeing which one performs best. So most mornings, this is an example they gave, they're testing whether heading on the left, about $2 billion worth of free media for Trump, performs better than the one on the right. Any guesses as to which is best? Who thinks the one on the right? Yeah. One on the left? So the $2 billion was 300% more effective than the one on the left. So they do this pretty much every day, and then pick the better performing one for the afternoon. You've also got other examples that are slightly more perhaps controversial that you might have seen in the press. So Pearson did a study a few years ago where they, before students took a test, they showed them either some kind of messages emphasizing a growth mindset or messages that didn't. And they found that those that saw a growth mindset were more likely to persist in trying to do difficult questions than those that didn't. And again, same principle, you're randomizing people to get one thing or another and then quickly seeing which works and then doing what works. So what about in healthcare? So as I said at the beginning, I work at NYU. So for a bit of context, it is a very big hospital system, 3 big hospitals, a large amount of outpatient clinics and a lot of primary care. We have about 44,000 staff, 2,000 beds, and 8 million registered patients, but this is not a kind of NHS system. Those patients might come to us for one vaccine, or they might have huge amounts of care with us, but a lot of people that we touch on a daily basis. Oh. I really clearly have very heavy fingers. Okay, so we are in NYU, as it's been discussed a lot today, trying to build a learning healthcare system. It's a really central part of the way NYU thinks of itself as a hospital system. Okay, there we go. Okay, so what are we trying to do? So, as I'm sure many of you know, there's lots of different approaches to try and do a learning healthcare system. So we know about QI already. used extensively on the front line. It's flexible, but the problem is, as we all know, it often gives us quite weak evidence. We don't really know if something was effective or not. There's also RCTs, great, robust, gold standard of evidence, but often slow, expensive, burdensome, and they're kind of inflexible. You've got to start doing something and then do that whole thing for a year or two, and that's just not really practical for how hospitals run. And then we have, as I've talked about at the beginning, stuff like A/B testing, used extensively in tech. It's rapid, it's quick, but it's not really used very widely in healthcare systems. And is that something we should be adopting? Right, okay, I'm going to try and click it just once. Okay, so basically at NYU we try and combine the best of each of these to run studies that are short. So our studies, ideally between 1 and 3 months, some of them run for as little as a couple of days, some of them do last longer. Every single one of them is randomized in some way. Sometimes we have to be a little creative about how we randomize, but we're always randomizing. Crucially, they're repeated, so we never do a study just once. We do it once, it might work, it might not. Even if it works, we iterate it and we try again, and we're keeping testing, keeping changing things as we go on and on. And crucially, they should also be no extra work for the front lines. We're trying to act entirely in the background and not come in and tell frontline work because they need to do something different or add an extra burden to them, because if we do that, they just won't do it. And I think that's particularly relevant as we think about working in a system under pressure. Okay, so half the battle in doing this well is to pick the kind of right projects, and the way to do that is these 4 things I think are absolutely essential. So the first thing is, obviously, in order to be fast, we have to have a lot of volume. We have to have a lot of patients or events. If we're going to have 5 patients in a year, we're not going to quickly get a result to know if something works or not. So we have to pick projects that we have a huge throughput of people. So screening reminders, things that you're doing hundreds of times a week. Secondly, we only use data that are easily obtained and routinely collected. So we don't, for the most part, ever collect data ourselves. This is stuff that already exists in our EHR. That means sometimes we're picking outcomes that might not be the perfect outcome. It might be a short-term outcome. It might be kind of a rough approximation. But we're going for the pragmatic outcome rather than the perfect outcome. And linked to that, we're also measuring outcomes that are short-term. So we're not going to look at the long-term health impact of something. We're seeing if it works in the immediate thing. So we might look at whether an appointment was made rather than whether someone had an improvement in the quality of life. Again, because we're trying to quickly see if it works or not. And lastly, obviously, to emphasize again, you have to have some way of randomizing it. I didn't even touch it at that time.
I think the tech team has a suggestion for you.
Cool. Okay, can we go back a bit?
You can
Okay.
give a shout perhaps to them.
Cool.
Go to the next slide.
Okay, so first thing I'm going to give an example of is a project we did on pediatric vaccination rates. So next slide.
You can't see the tech team in the background is wiping the sweat of their brow. To make this work.
I'm glad it's someone else's problem now. So it's really annoying because I also revealed the answer now. Anyway, so this was, as is probably also true in the UK, it was a massive drop-off in paediatric vaccination rates during the pandemic in routine childhood vaccinations. Big problem. So our primary care clinics in the kind of deprived areas of South Brooklyn asked us to come and help them work out how to improve that. We ran a bunch of focus groups with parents to try and understand why they weren't bringing their children in for vaccines. And based on that, did a round where we tested 2 messages, one about safety and cleanliness, one about the importance of vaccines against no message, to see if that would be effective at raising appointment rates. What did any bets? What were people? You're all wrong, and no effect. It was no better than no message. Next slide, please. Okay, yeah, so there's no effect, which I think is interesting, not just because we were obviously trying to be evidence-based, there's also plenty of evidence from elsewhere in the literature that would be effective, and it wasn't. We tried again, then there was a round 2 between these 2 things where we tried no message against a basic message, also no effect. So round 3, and this is the point about iterating, we went back to the families, we talked about why they weren't responding, and 2 things came out. 1, I just forgot. And 2, we were messaging them at the end of the day when it was outside their work hours, but when our call center was closed. And so obviously they were ringing to book an appointment, and then it was closed. So we came up with this third idea, which is we'd set 1 text and then send a reminder 40 hours later. And finally, which you've all seen now about 10 times, this slide. Next slide, please. There we are. Finally, we actually showed an effect. So we had 3 times higher. So this is the one on the right, so a day after second text, showing a 3 times higher appointment rate in the intervention group versus the control. And we also showed higher vaccination rate as well. Again, it might not be a massive proportion of people booking an appointment, but it is a big difference and a significant difference. Okay, next slide, please. And then I just wanted to give one other slightly more complex example. So that was a kind of basic A/B test of like this, does this message work or does that message work? We can also be a bit more complex and think about how we use the method to prioritize our resources. So this was a project looking at reminding people to come to their screening appointments. And we, every year, are supposed to call all of our patients and remind them to come, which is very resource intensive. And so we wanted to answer two questions. So one, do the calls work? Is it useful? Are we wasting time doing this? And two, given we can't call everyone or we don't want to call everyone, who should we target? Should we target those most likely to attend by themselves? We just needed a little nudge. Or should we target those least likely to attend by themselves and they needed the impact? So we built a model to predict attendance, split our population into quartiles, and then randomize within each quartile to see which was the most effective to call. And, next slide, please. Oh, and now we're missing all the bars. Well, anyway, so what you can't see here is there's in fact 4 bars, which show that this was by far the most effective for people who are at highest risk of not attending by themselves. So it basically showed that we needed, if we were going to call people, we should call people who weren't going to attend by themselves. And what's interesting about this is we've repeated this kind of approach for different studies. So we've also looked at calling people who are not taking their medication and how we encourage them to take the medication, and we showed the reverse effect. So in that group, we're only effective in calling people least at risk. So it kind of, again, shows us that you can't just, even within one healthcare system, you can't apply one rule from one bit of your system to another. You've got to keep testing and keep iterating. Next slide, please. So yeah, this is my conclusion. The first thing is that it can be done. You can do this kind of randomized, robust testing and get robust answers, and you can do it quickly and pretty cheaply. It's also useful, and it's really useful because just because something worked there, like a lot of the things that we do are evidence-based. They've worked somewhere else. They've worked somewhere else in our system. They've worked somewhere else in the US, but then we try it in our system and it doesn't work. And if we didn't actually test it, we'd just be going on doing these things that were not worthwhile. But most trials fail, by which I mean very often they show no results. Most of our trials, the first time we do something, it's not effective. Therefore, you've got to come up with a system by which you can do this repeatedly and not get everyone sort of disappointed or like lose faith in you or have felt like they've wasted a load of time and money. So you've got to find a way of making it routine and low effort, which again, tech does all the time. You know, why can't we do it in healthcare? It's not necessarily rocket science. That's me.
Thank you.
Great. Well, thanks very much for the invitation. Great to be here. So, my name is Dimitri. I'm a clinical lecturer in public health at the University of Birmingham. So kind of talk a bit about the research we did before the pandemic and then how we've learned during the pandemic to perhaps do some things a bit more rapidly. So I work in the global surgery unit at the university, and the kind of basic starting point is that we know that globally there's a massive lack of access to safe, affordable, timely surgical care. And historically, high-income country involvement in global health settings has been around short-term missions, what some people call parachute research, where people come in, collect some data and leave, not very sustainable, not very equitable or ethical. And to get around this, we set up a group back in 2014 called Global Surge, which we were trying to set up to be a more equitable and collaborative platform for global surgery research. And since then, we've sort of expanded from doing cohort studies to doing multi-country randomized trials, and it's all based around research for public benefit and capacity building research capacity. Core to this is our hub and spoke model. So this is an example of our hub and spoke model in Nigeria. So we've got 7 hubs in total. They're funded by the NIHR Global Health Research Program. And in each hub, in each hub country, there's a hub which is going to be a big university hospital, generally which is led by a surgeon. They've got a team around them, research nurse, admin people, finance officer, and they reach out across their country, across a spoke network. And these are smaller hospitals, might be university hospitals, some will be district hospitals, some will be rural hospitals, and they're running multi-center studies across these networks. And they are in Benin, Ghana, India, Mexico, Nigeria, Rwanda, and South Africa. And we get together every year where we discuss the work we're doing and we co-prioritize with the network, with patients, what our future research should be. So that's what we were doing before the pandemic. These are the sort of directors of all those hubs around the world. One of the trials we ran was Falcon. So this was a randomized trial, quite a big randomized trial, about 5,700 patients randomized across those 7 countries. And we were looking at whether any of these 2 interventions, basically alcoholic chlorhexidine versus povidone-iodine, which are different types of solutions to sterilize the skin, and then different types of sutures, whether they were coated or non-coated with triclosan, which we used to close the abdominal wall when we're doing surgery, whether those would reduce wound infection. So by working through this hub and spoke network, we were able to recruit those patients in, I think, just over 2 years, which for a trial of that size in surgery is actually quite a big achievement. Unfortunately, when the results came out, so they were published in The Lancet, I think a year or 2 ago, it basically found that there was no reduction of surgical site infection with either of these interventions. So surgical site infection means essentially wound infection. So a bit like you just heard, big trial, lots of effort, negative study. Not a complete waste of time, because it means that we don't need to spend money on these more expensive interventions. But yeah. So then we did another study called Cheetah, which this was a cluster randomized trial. So rather than randomizing individual patients, we were randomizing hospitals, and those hospitals were randomized to whether or not the surgeons in those hospitals would change their gloves and instruments at the time they were going to close the abdomen after surgery. So you can imagine if you're doing abdominal surgery, your gloves can get and your instruments can get quite dirty with, contamination from poo, maybe. So the question was, should we routinely change our gloves and instruments at the point when we started closing the wound so we don't kind of contaminate the wound? So to this study, we recruited 13,000 patients from 81 hospitals. And the good news here is that we did find that actually routinely changing gloves and instruments does reduce wound infection by about 13%, which may not sound like a big difference, but if you think about, globally we're doing 300 million operations a year, roughly. Wound infections occur maybe 10% of those operations, so a 13% reduction overall worldwide is a huge patient benefit. And we were able to deliver this quite quickly, just I think in about 18 months, because of this cluster randomized technique, which is a bit faster. So how do we get lots of people involved in our research? Because this depends on lots and lots of people getting involved, consenting patients, delivering the interventions, collecting the data. And the main thing is really about inclusive authorship. So making sure that everyone who takes part is able to take credit and have ownership over the sort of scientific outputs. So we generally publish our papers with a single name on the top. So on this example, you can see the name on the top is COVID Surge Collaborative. And then at the end of the paper, you list all the individual collaborators. So one of the achievements we have is a Guinness World Book of Records record for the most co-authors on a paper. So we've got a paper with 15,000 co-authors. So I think the previous record, if you Google it, people still say the record is some physics paper with about 4,500 people. But anyway, we've got the certificate, so it must be true, right? So just briefly to tell you about COVID Surge. So when the pandemic started, because we had this global network of collaborators, people were really worried because they were seeing that COVID was spreading and what was going to be the impact on surgical patients and what should they do to keep their patients safe. So we set this up as a global response to collect real-time data to guide safer surgery during the pandemic. So in the end, we probably had over 20,000 people collecting data across the different studies, across more than 2,000 hospitals in 120 countries. We've published quite a few papers, including a couple in The Lancet and Lancet Oncology. So the thinking behind this is other people in the UK, for example, have published analyses using HES data, And HES has the advantage that, for those who are familiar with it, it's sort of a big national data set you get for all NHS patients having any kind of admissions. The advantage is it's very big, it's comprehensive, national data. It lags a bit behind in time. It takes a few months for that data to come through. And it lacks a bit of granularity around some of the data you might want, particularly when, early days of COVID, when people probably wouldn't have been coding COVID as a thing in HES. So that's why we wanted to collect real-time, rapid data. So we did these 4 different cohort studies over a couple of years, looking at different things. We were able to come out with some really clear recommendations for how we could keep patients safer. So, I mean, this isn't a surgical conference. I'm not going to go into all the detail. But essentially, there were some really key things that people could do. And then we really focused on, we're very good at doing research, but we're not very good at sometimes at implementing that into practice. We don't really want to just publish something in a journal and for that to sit on a shelf. So what we tried to do was work with our global collaborators to implement this into real-world policy. So we worked with policymakers to implement it into guidelines, and we got the various papers press released through the local universities and hospitals of our collaborators, and that really amplified the media coverage. So we were, we actually had a lot more coverage globally than in the UK, in most of the main newspapers around the world. So just last couple of slides. What have we learned? Well, we were building on some good foundations we had. So we had an existing global network where we had already tried to build inclusive leadership and authorship models to kind of encourage more people to get involved. We had probably about 10 years of experience of designing and delivering pragmatic studies. So we knew how we could try to keep them simple and focused so that at a time of everyone would be really stressed and busy, how can we collect the least amount of data to get the most possible information out of it to avoid, too much complexity. We had that NIHR funding, which was really useful to kind of provide some of the basic infrastructure that we needed. But we also learned something during the pandemic through that experience. So there were some health systems, particularly in the United States, I have to say, where there was a big step change in ethics and data sharing approaches during the pandemic. Before the pandemic, it was really difficult to get anything started from the UK. In that first wave, some of those barriers were broken down. Having a disseminated leadership structure by empowering country-level leads meant that those people brought their own networks on board. And so it wasn't just about who we knew, but, kind of chains of people who would get each other involved. We use social media quite a lot, both to disseminate the opportunity to get involved in the study, but we also use things like WhatsApp to keep in touch with people on a regular basis, good lines of communication so that things could get done really quickly rather than relying on slow email communication. And I think big part of this was about identifying common important research questions. So how do we done a study looking at the impact of COVID on gastric surgery? We would not have had the same impact by going for what is the impact of COVID on all types of surgery. That increases the pool of people who are going to be interested in taking part. And there's lots of other topics where I think in the future surgeons and anaesthetists can have big collaborations. Designing our statistical analysis plan in advance meant that we could start a slightly different way of doing analysis maybe, where we would have a pre-planned analysis. We could start that on a data that we had at a point in time when we thought we had, okay, we've got enough data to start doing an analysis. And then we would update those analyses after submission to the journal. So, for example, with our first paper, we submitted it to the journal when we had 400 patients. They reviewed that, asked for changes. When we were making those changes, we increased it to 1,000 patients that we had by that point. Rather than waiting, okay, let's wait until we have 10,000 patients, which is going to take months and months. And we really tried to pre-plan how we would disseminate our findings, whether through working with press offices to get it out into the mainstream media, planning social media, multimedia campaigns, proactively engaging with policymakers, and producing simple toolkits that our collaborators could use in their own hospitals with their own national surgical and aesthetic societies to try to implement some of these findings. So I think, going forwards, the focus for all of us needs to be about how can we build on some of these lessons that we've learned so that we don't go back to the days of it takes 5 years to get a study done. How can we do things really quickly to realise the benefits that our patients need? Thank you very much.
Hi everyone, thanks for the opportunity to speak this afternoon. My name's Ruth Cousins. There we go. I'm the CEO of a company called This Labs. This Labs span out from the University of Cambridge yesterday. So this is very new for us. Prior to that point, I was part of the this institute at the University of Cambridge, which is the Healthcare Improvement Studies Institute. And both things, the institute and This Labs, are supported very generously by the Health Foundation. So big thanks to them for that. So I'm going to talk to you a little bit about what Discovery is and what it does, and also specifically about some of the evaluation type projects we've used it for. So Discovery has been developed to enable the health and care system to improve and innovate collaboratively, which is a kind of grand aim. To get down to the specifics a bit more, so what it actually is an online platform providing the capability to do lots of different tasks, so understanding problems, gathering evidence, doing evaluation. And what we're trying to do is kind of do that in these kind of 5 very specific ways. So scale is very important to us. We want to do things that involve lots of people. So our biggest project, I think, was around 1,200 people who were co-designing some tools for supporting the monitoring of labour. We've had smaller projects. I think our smallest one was probably about 25 people, but that was with the parents of children who have very, very rare conditions. So in terms of the cohort, it was quite a big group of people. We are also interested in working across geography. So we have this phrase, start at scale. So what we're trying to do is involve people from across the UK and in doing these types of pieces of work, all at the same time collaboratively, to draw out the kind of cross-cutting messages first and then enable the localization of those messages afterwards, rather than finding out things very locally and then trying to, I think the phrase is lift and shift. So that's another kind of principle we try to work to. Speed is very important to us. So I think the quickest project we've ever done, we got up and running and completed in about 6 weeks. That was right at the beginning of the COVID pandemic, and it was something that was very pressing to redesigning services at that point. Typically, a project with Discovery might be between 3 and 7 or 8 months, something like that. So the use of online enables us to get things going very quickly. We are a platform that was developed in a research institute for researchers, and using and basing our work in scientific rigor is very important to us, but we think it also has really important impacts for the trust that people have in the type of work that goes on Discovery and the confidence they feel that their contributions will be used in an important way. We're also very keen to be engaging and inclusive, and also to deliver specific actionable insights. So we're not a collaboration platform that kind of asks for generalities. We're always engaged in a specific project to try and achieve a particular goal and have impact that way. So that's what Discovery looks like. That's the front page of Discovery. If you go to discovery.org, you can have a look around. There are demo projects on there that show you some of the work that we've done before, and you'll see some of the projects that we've engaged in. So although we have onlines in our kind of research underpinnings, there are lots of different types of things that we use Discovery for. So crowdsourcing, for example, co-design, evaluation, prioritization, building consensus. And the aim is to be a very kind of broad-based tool that lots of people can access and use. But more than that, what we're really trying to do is build a community around these types of activities. So we want people to come back on a repeat basis and engage with discovery projects over a period of time. And we're quite proud of the fact that some of the multi-stage projects that we've done have had really good retention. So 75% of people coming back for 3 or 4 or 5 stages of research projects and engaging over that long period of time. And taking some of the learning from citizen science, where they find that they have groups of kind of super users who are very particularly engaged and even sometimes go on to become researchers and authors, etc., going forwards. So we have completed about 20 research programmes over the last 3 years. We measure what we do in terms of tasks. So a single interview study, for example, would be a task. We've done about 65 of those over the last 3 years, and you can find lots of information either on the Institute's website or on our website about those. But to give you some examples of evaluation type projects we've done. So this project was a study that we did in partnership with NICE about the inconsistency of implementation of their guidance on end-of-life care. It was a multi-stage study. It had interviews study in there, it had surveys, it had consensus building. We had about 500 people participate in a consensus building process, which has helped to identify what good looks like and think about how the guidance might be written differently or changed in order to improve better implementation. And that was towards the end of last year and the beginning of this. It was about 6 months, I think, altogether. Another one is a project that we ran during 2021. Again, I think it was about a 6-month project looking at how the experiences of remote antenatal care during the pandemic might help us to understand what good looks like for remote care more generally. It used similar methods, again, surveys and interviews. There were about 100 interviews specifically on this. And the reason that I chose this project is because it's a really good example of how we've been able to use discovery alongside offline approaches. So some colleagues of mine did fantastic kind of work with communities and network building in order to encourage them to come and participate on discovery, but also offering offline contributions as well, because not everybody, as we all know, can access an online platform. Another couple of examples there in a bit less detail. So one around secondary mental health services, and another one that's currently ongoing at the moment around evaluating the role of NHS patient safety specialists. So in terms of reflections of what we've learned from the last 3 years of running projects on discovery, we think being able to set up really quickly means that we can be very relevant, and that means that we get better engagement. So at the beginning of the pandemic, we had lots of people falling over themselves to be involved in our projects because they could see that this was important, necessary. We needed to sort this out now. Back to what I said about start at scale, we think that that's a really important additional way of trying to produce change and innovation in the system. And I would also reflect that whilst online approaches can be very accessible because they mean you can participate whenever and wherever you choose, user experience is absolutely vital because we're all very sophisticated consumers now of online experiences. And if something doesn't work or it's boring or it's clunky in whatever way, we give up on it very, very quickly. So user experience has been a really key focus for us. And I think some of these messages have come out in other sessions today, but valuing participants' time and expertise, being really clear about how long it's going to take them to participate, what the outputs are going to be, how their data is going to be used is really, really vital. And again, using communication to build up that sense of community and to get people to come back and participate in multi-stages of the projects has been really vital as well. So that's Discovery. Thank you.
We can start with a round of applause. And I skipped on my own introduction. So I'm Jan van der Scheer. I'm a senior research associate at this institute, the Healthcare Improvement Studies Institute. Up to yesterday, a direct colleague of Ruth, and now after the spin out, a little bit differently. What I'd like to do next is we kickstart the discussion a little bit with some of these cross-cutting themes, hopefully to give you some ideas to move from some of the challenges that we discussed in the session in the morning to ideas for solutions that we can take home and start using in the time up ahead. And I'd like to start with Ruth. Thank you, Ruth. Absolutely exciting to hear more about this. And I was thinking about some of the topics also, for example, the rapid RCTs that Holly spoke about, and also thinking about these more, for example, global collaborative approaches. What kind of roles, if any, do you see for a platform like Discovery for those types of things?
So I think the important thing about, I don't know if I'm close enough to the mic, but I think the important thing about Discovery is it's a tool, and it's a tool that you can turn to all sorts of different uses. And one of the things that we're really excited about doing is kind of marrying two different types of data together. So some of that routinely collected data alongside some qualitative data, and how we can bring greater insight into not only how things happen, but also why they happen and how they might be amenable to change going forward. So I think particularly I can see that being potentially helpful in either of these situations. But I think it's really about again, those questions of what's your underlying infrastructure. And I know that you, Dimitri, you had RedCrap was the kind of tool you use. So it's another tool in that. But I think also it's that opportunity to build communities. So that's very much our kind of focus. And whether that's a local community or a community around a particular condition, or even the community of the UK, all the users of health services, there's an opportunity to kind of generate that feeling of coming together to contribute, I guess.
Holly, is that something you also recognize in the ways of how you've been working? And perhaps you can also use the opportunity to expand a little bit on the, you mentioned a few times sort of we have made this happen, and maybe some of the team approaches as well as the platforms you've been using to make this happen.
Yeah, sure. So in terms of the we, I think one of the most important things about my team is that it's embedded within the hospital. So we don't do anything ourselves. We don't run any interventions. We don't even come up with the ideas. They're all from the frontline staff. They're things they're already planning on doing, or they're interested in, or something that they do and they're really annoyed about it and they think they should not do it anymore. So it's very much a collaborative approach. All we're doing, similar to you, is giving them the tool, and the tool is an RCT, to show whether or not what they're doing is effective. So that's, I think, very much the attitude. And I guess I'd echo, I know I gave a whole presentation on RCTs and how they're really useful. I'd actually never run an RCT until I ran this team. And they're very much just one method. You can't just have that. You also need qual, you need other sources of information. You're not going to have any ideas unless you talk to people, unless you observe and go and sit in your hospital and look at what's happening. So it's very much a collaboration of both different methods and different people.
Thank you. And Dimitri, with this, I mean, you have this enormous and a very impressive network that you are running. So how do you source ideas and feedback and gain some of these new inputs from over 15,000 people who are part of this network, if not more?
Yeah, so I think it's really important to have a two-way dialogue with the collaborators, because I think one reason why people get involved in multiple studies over time is that they kind of enjoy it and they enjoy being part of it. So I think what we try to do, it's not possible to have a dialogue with 15,000 people, but we have a dissemination committee which has several representatives from each country who can sort of talk to their colleagues in the country and then feed back to the wider group to sort of try to have a discussion, identify research questions, prioritize these. Then we can start to draft a research protocol, share that with everyone for comment. With a large group of people, so this is where things like Google Docs come in useful, and then have ongoing communications with the collaborators, so that over time you're updating them on progress, and then when you get the publication, again you feed back to people. We've published this. This is the impact, and this is how you might go away and implement this in your communities. So I think it's kind of getting that front line engaged. Throughout the whole process is really important, because then that's what leads to more people getting involved and higher quality, higher volume data. Because I probably didn't explain, but essentially what we're relying on is for those individuals in different hospitals to go out and collect data on patients in their hospital and enter them into an online system, so that we then have data on hundreds of thousands of patients from around the world. So it's quite a big effort for them, but hopefully it's worthwhile.
Thank you. And Ruth, does this resonate with you? You spoke about starting at scale when you hear 15,000 people, all these many hospitals. So how do you sort of look upon that, and perhaps ways how like online platforms can help facilitate that?
Yeah, I mean, I think it's vital really to be able to do that work online, and it's a tool that everybody can use. So I think I think I don't really know what more to say other than that really. So I think from our experience, it's about putting the tools on that platform that are useful to the specific circumstance that you're trying to do. So it may be a very simple data gathering exercise, but if you're trying to get under the skin a bit more of people's opinions or their everyday lived experience, that there are kind of a different set of tools which we use in order to be able to manage that, I guess.
Yeah. And Ali, when we switch back to you're working in a very large setting, but arguably it's still one particular hospital setting. Is it fair to say that?
Yeah.
Do you see would you see that as a scaling up or starting even more at scale when thinking about doing this elsewhere? Or would you say it's probably better to work and have a lot of these kind of separate systems running alongside, maybe learning from each other, but still running separately from each other?
Yeah, I think they kind of need to be separate. I think the point is that you have a team like mine embedded within big-ish hospital systems, because the point is that I gave with my examples is that you can have the most evidence-based, intervention in the world, and it just doesn't work, or it doesn't work optimally, and you've got to tweak it for your particular population. And even within NYU, we have 3 hospitals, very different areas serving very different populations. What works in one won't work in the other. And my team is 6 people. It's not super specific skills that could exist within an existing hospital network, within the analysts they have within a hospital. And it's just about doing a slightly different kind of research or a slightly different kind of analysis and applying it to your system.
And are there opportunities so you say, 5 or 6 people are working in this relatively large NYU sort of setting. Mm-hmm. Is it possible to do it on a smaller scale? Or maybe I can also rephrase, if you were thinking about using this across the NHS, how would you go about with that if you are a small hospital, mm-hmm. or a small trust, and if you are a larger one?
Yes, I think there are really just 3 things that you need to make it work. So you need to be embedded in some way, which means you need access to the front line and relationships with frontline people who want to try the things you're doing. You need leadership, sponsorship from leadership. So we report directly into our chief executive. So you need some kind of senior sponsorship. And most importantly, you need data, like quickly. Your team needs to have access to that data. So you could have, 1 or 2 people that had that, just an existing data analyst in a hospital and some senior sponsor. And you could start small with 1 or 2 projects. You pick the things that are easy, messaging being an obvious example, before you scale up to do more complex kind of things. So I think it's definitely, I would say that, but I do think it's definitely doable.
Thank you. No, thank you. Before we switch to some of the questions from the audience, and maybe we can have the Slido overview up in a moment, I thought I would like to ask maybe perhaps to both Holly and also to Dimitri about your experiences with governance and ethics running these types of things. So perhaps Dimitri.
Yeah, so obviously ethics is really important because it's there to keep patients safe, so that there's a reassurance that we're collecting data in a safe way, we're not losing data, and so on. The challenge when you're working across lots of different countries is that each country has its own governance framework, which you have to navigate. So one study, you could end up getting 3-4 approvals in 3 or 4 different ways. It might be registered as audit in the UK, but it might be registered as research in Italy because they don't have a concept of clinical audit, for example. And in some countries you might need patient consent, individual patient level consent. In other countries you might not. It all kind of depends on what the local laws and regulations are. So again, that goes back to why it's so important to have really empowered local leaders who really understand those regulations and can navigate them for you and make sure that's done safely. I can say that on one occasion there has been, after a paper got published, there was a complaint from somebody. Bizarrely, somebody in the UK alleged that we hadn't got patient consent for patients in another country. And you know, how they knew that, who knows. And they made this complaint to the journal, who were obviously concerned. But because we had a really effective national lead in that country, they were able to kind of supply all the documentation to prove that all the relevant approvals were in place and that all the local laws had been followed. So, you know, that was resolved quite easily. So it's really important to have the right people in place. It's not something that, you know, just sitting in the UK we can make happen without lots and lots of people collaborating.
Thank you. Holly?
So yeah, a crucial thing about us is that we don't take patient consent. We don't get consent for any of our studies, and we don't go through ethics approval. So the main reason for that is we view it as QI, and QI in the US doesn't need ethical approval. We're not testing necessarily new things. They're well-established interventions. We're randomizing their rollout, as it were. And it's pretty important to us that we don't have to go through ethics approval, because if we did, it would massively, massively slow things down. The slightly more problematic reason we don't go through ethics approval or ask consent is because we think people would often refuse. I don't know if you've seen, there's an interesting study by someone called Michelle Meyer, which looks at people's views on randomization. And it's a quite clever study where they ask people how they feel about, like, a doctor having a badge saying, like, ask me any questions, and having a poster in a room saying, ask me any questions. And, like, do you have a problem with either of these interventions? And everyone's like, no, that's fine, it's a badge, it's a poster, I don't care. And then you ask them if they have a problem if they were randomized to get one of these or the other one, and people have a massive problem with it. Like, people don't like the concept of randomization. And and we sort of slightly get around it by being like, well, healthcare systems should learn, we should be constantly improving, we have a duty to improve and to see if things work. But we're also slightly treading a line, I think, because it's very likely that if we ask people, they wouldn't be happy with some of the things that we randomize.
So I hear a balance between different ethical values that we want to live up to, both the value of producing results as well as the value of making sure that people are sufficiently consented to take part in things that are impacting their lives.
Yeah, and it's not even just, they don't even know that they're being randomized. So.
Thank you. I'll turn to the audience, and we'll see if we can get the Slido overview up. So well, I think one of the top ones, ethical approval. I think we just covered that. Ruth, you probably see. I don't know if you can see the next question about the challenges. Maybe you can touch on that one.
Yeah, I think it's really, really important, and I sort of slightly touched on it towards the end of my slides, which is that people's time is very, very precious, and it's really important to be clear about how much time you're going to take, and by and large to take as little of their time as you possibly can. And sometimes that does have a bit of or it does bring us into a slight kind of conflict with the research design, because sometimes people would like to ask 85 questions, and there's absolutely no way that people will go through 85 questions, particularly on an online platform. So one of the things that we try to do is work really closely with our research teams to try and optimize that user experience and to make sure that you're using people's time really well, because it's a really, really valuable commodity for the people that we're working with. So we've got about 8,500 registered users on Discovery at the moment, and we think about 60% of those are people who are working in the system. And obviously we all have different identities, but it's really, really important to us to kind of maintain their trust by being really open and honest and valuing their time.
Thank you. And perhaps we can pick up the next one as well about the risk of digital exclusion.
Yeah, it's so interesting. So I guess we've done this development of Discovery in a really interesting period because we did our first kind of big project in April 2020. And so we have all changed our attitudes to doing things online since then, right? And I think that digital exclusion is absolutely a thing. And again, I touched on one of the studies where we worked hard to kind of bring offline and online approaches together. But actually, we, in many studies, offer a way to participate offline, and we get almost no take-up at all. So I think that people are obviously becoming more and more digitally enabled and more comfortable in participating in those ways, but it shouldn't be taken for granted. You can't assume that that's going to happen. So we always want to offer both routes.
Thank you. Holly, sharing the findings of your RCTs, could you say a bit more about that?
Yeah, so I think we always view our primary audience as the hospital itself. So we're not just about sharing findings, we should implement our findings. So the text message example I showed is now what we do standard. We now also always send the call centre team a risk-stratified list of who to call, and they call the top quartile. And I think so. The main thing we do is not just share our findings, is implement our findings. But we do then also publish. I guess the thing to say is that often our findings, they're not that interesting in and of themselves. Like a text message reminder, it's not a fascinating study. The method by which we've come to it is the more interesting part, I would say. So that tends to be more what we talk about and share.
And thinking about understanding working mechanisms. So, for example, if you see that a number of things where you say, okay, well, we just tried out a bunch of different text reminders, but there's, of course, ideas that feed in why you're choosing to innovate and try different things. Is that something you're thinking of or doing, and then basically be able to then come up with even better solutions that you can try out that are more likely to be successful from the start?
For sure. And so for example, the text one, that was in a paediatric clinic, but then we work very closely with our central comms team, and we fed those findings into the comms team. So actually now almost all their text messages go out with reminders because we've shown in one setting and it worked. So, and it costs us nothing to send a reminder, so why wouldn't we just always send a reminder? I would also say the theory behind why something works, like I'm sure many of you know, an RCT doesn't tell you why it works, it just tells you that it works. And I think to some extent we kind of lean into that, not getting too caught up in trying to understand why or prove why. It doesn't matter. We can just run a bunch of tests and see if it works or not, and then kind of not worry about it. And that's, I think, also an important thing to take on board.
Thank you. We can see perhaps if the technical team can change at the right top the popular to the latest questions, then we can see. Yeah, perfect. Any more if we scroll down? And otherwise, I will open up to the. So AB approach, has it been used with health professionals, for example, to improve use of protocols? Yeah,
so lots of our studies are like best practice alerts or in-basket messages or reminders to clinicians. There's tons of things we do. We've shown, one of the interesting things about that is they tend to be effective initially, and then if you follow up a few months later, you find they stop being effective. So that's one of the things we want to work on, is how you keep a alert fresh. We also spend a lot of time, so in the US, everything is electronic health record. It's hugely burdensome because they have to document everything for insurance. So a lot of actually what we do is getting rid of alerts. So we've done a lot of trials which is to try and get rid of if we get rid of this alert to tell you to give someone a flu vaccine, can we get rid of things without you diminishing the flu vaccination rate, stuff like that.
Thank you. And another one was about if you get little effect in first tests, are you doing any learning across all the tests to inform principles, things not to do? So it's a little bit perhaps the working mechanisms question.
Yeah, I think the same sort of thing. We do try and share it more generally within the hospital, but also not get too caught up in thinking we know why something worked or didn't work, because we don't actually know.
Thank you. Let me see if if we can scroll down a tad bit more, see if there's any further questions. Then, is there anyone in the room at the moment who we have a couple of minutes left, maybe one or two final questions, if any? Well, then what I'll do is maybe are there any final remarks that for all three of you, any final remarks that sort of in light of the take-home message of thinking about solutions in light of challenges in a system under pressure?
I guess the thing that I take from Holly and Dimitri as well is that even though systems are under pressure, there are people who are willing to contribute to this type of work, and there are interesting and kind of fun things that you can do to try and move things on. So it's easy to, I guess, get into a bit of a council of despair and think, gosh, everything is so terrible, it's so hard, and it's terrible and it is hard, but you can actually still make improvement, I think.
Thank you.
I guess my reflection would be that I think there is still plenty of people interested in getting involved in research and evaluation, but we just need to support the front line to do that with resource. So making sure people have the time to do this, that the research projects have got sufficient funding to kind of function efficiently. So, my thinking is the NHS is under a lot of stress, but can we think about how can we support medical, nursing, allied health staff to have, half a day, a week, a month that they could spend on quality improvement, research projects. I think, they'll take people away from the front line, but maybe that would mean that we could really move things forward over time, because at the moment people just don't have time to reflect on what they're actually doing. So we need to just support people there.
Thank you. Holly?
Yeah, I think the same thing. Just to emphasise that it can be done. The frontline staff are very busy, but most of our studies aren't giving them any extra work. We're just saying, you're already sending a text message. Why don't you send 2 versions of a text message? And don't worry, we'll do the analysis to see if it's effective or not. So it can absolutely be done in a way that isn't putting lots of pressure on people. You just have to find the right projects to do that with.
Well, thank you very much. A big applause for the speakers.